Good morning. First of all, I would like to apologize. I'm not with you today, and it is unfortunately for health reasons, not so severe, but I cannot travel with the disease I'm suffering now. And I would like to cover with you the ANCA-associated vasculitis and more specifically, the therapeutic approaches. Here are my conflicts of interest. The main characteristics of this vasculitis are shown on this slide. They affect small side arteries, capillaries, and venules. There is two ANCA subtypes which are useful for the clinician, which are the anti-myeloperoxidase antibody and the anti-proteinase 3 antibody. If present, lung and kidney involvements are the consequence of capillaritis. And lung hemorrhage can be observed, sometimes severe, but not all the time. And a glomerulonephritis, a rapid progressive glomerulonephritis, can be present. Granuloma is observed in GPA and eGPA, but not in MPA. On this slide, you see the ANCA. On the left, you see the C ANCA, and which is green, and the nuclear is black. And on the right, the P ANCA. P ANCA corresponds mainly to anti-MPO antibodies, and C ANCA to anti-PR3 antibodies when they are searched in ELISA. ELISA is now the technique which should be used to make the diagnosis of ANCA-associated vasculitis, and immunofluorescence is not sufficient for that. On this slide, you have the Chapelin nomenclature. I will show you later on another slide with also the ANCA vasculitis on this nomenclature. It is a small group of the small side vessel vasculitis with three diseases: microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis, formerly called Church-Rose. This one, GPA, was Wegener's, and MPA is MPA. And the ANCA have a major importance for the diagnosis. In GPA, more than 80% of the patients are anti-PR3. There is some rare patients which are anti-MPO. In localized GPA, it's only half of the patients which are positive for the antibody. And in MPA, it is also 50% in the population of patients which are recruited with general symptoms, arthralgias, purpura. But of course, if you focus on the subpopulation of patients with kidney involvement and lung involvement, anti-myeloperoxidase antibody are present in more than 90% of the patients. In eGPA, it is different. It is approximately 30% of the patients which are positive for ANCA, and they are anti-MPO. And it's for another reason. eGPA is an heterogeneous disease. Some of these patients are ANCA positive, and others have probably other mechanisms to develop the disease. And I would like to tell you, but you know that polyarteritis nodosa are all the time negative for ANCA research. And now when you look at all the new classifications and new recommendations, ANCA are really central to make the diagnosis. The clinical symptoms of vasculitis are present, and ANCA should be present in ELISA with one of the two antibodies. Now we'll go on treatment, because the major advances have been made on treatment of vasculitis. Some history. In the past, no treatment. After that, steroids only. But the first progress was 1979, when Anthony Fauci published a short series of patients who received cyclophosphamide in addition to steroids for severe disease, and most recovered. The second point is essential. It is a discovery of hepatitis B virus as the agent of one vasculitis, polyarteritis nodosa, and HCV in 1991 as the cause of cryoglobulinemia. After you have the discovery of ANCA, 1985 with Van der Voorde in the Netherlands, and anti-MPO in the United States, Janet discovered the antibody. And at the end, the Chaplin nomenclature. The Chaplin nomenclature is certainly the best classification system for vasculitis. And for me, I use only this one because it is really a very, very good one with very precise definitions of the diseases. This slide on treatment. It is not a very old series of patients. It is a retrospective study published in 1979. And you can see that at that time, some patients did not receive any treatment and the mortality was very high. This paper focuses on PN, but in fact, PN was not well defined at that time. And you have MPA together with polyarteritis nodosa, and ANCA were not known at that time. But the key message is that steroids is not enough in the most severe patients, and that immunosuppressants combined with steroids is more effective. But now, of course, we have better. First of all, how to treat the patients. We should adapt the treatment to the vasculitis type. You do not treat HCV cryo as you treat GPA. It is completely different. And we have potential items to consider to adapt the treatment. As I told you, the vasculitis type and the pathogenic mechanisms, with or without ANCA. The severity scores, the 5-factor score, is now well recognized by the international community as a tool to select the most severe patients and to propose the most aggressive treatments for these patients. There is also some scores or markers which can predict relapses, and the impact is not on the initial choice for treatment, but on the maintenance treatment choices. And maybe in the future, genetic markers could predict the long-term outcomes, but it is too early and we do not have any study to demonstrate that, but I'm sure that it will be certainly used in the future. And there is a new therapeutic era. Instead of immunosuppressants, there is new drugs. And these drugs are mainly targeted therapies, monoclonal antibodies, and they could revolutionize treatment of vasculitis, but did they really provide a significant benefit? And we have to study these drugs, drug after drug, with prospective trials. These new drugs are more expensive, and sometimes it's difficult to prescribe these drugs in some countries because it is very expensive. But we have also, when we use these drugs, to demonstrate that these new drugs are not only more or as effective than the previous one, but also that they are safer and they are efficient in terms of direct and indirect costs. Roughly, we can define and divide the treatment of vasculitis in two periods. The first one is induction of remission, which is now a short time, 3 to 6 months. And the conventional treatment was pulse cyclophosphamide, or oral treatment, if you like oral treatment, but really pulse is probably a well-tolerated drug, a way to administer the drug. And with a very short treatment, less than 4 months, you can obtain the remission. And after induction, there is a maintenance treatment, and the conventional treatment was azathioprine or methotrexate. This scheme is still used. And it is not a bad treatment, a bad choice, but we have, I think, maybe better. But the results of the conventional treatment, for some of them, are summarized here. NORAM, Sicasarem, Cyclops, MEPEX are some of the prospective trials organized by the European Vasculitis Study Group. And you can see that at 10 years, according, of course, to the severity of the disease, the survival rate ranges from 78% to 92%. Here it is the French vasculitis group studies. When we consider the best prognosis patient with 5-factor score at 0 point, at 10 years, we have 92% of survivors. And when you combine both, it's approximately the same, 92% survivors. In fact, with a good treatment, a very good, well-adapted treatment, you have really excellent results. And in the RAVE study, which is the first study published on the indication of rituximab as induction treatment, 99% of the patients survived at 18 months. And the first sub-conclusion of this talk is that now survival is excellent, whatever treatment is given, and rituximab is as effective as conventional treatments. You know that when we consider the RAVE study, the result of the treatment is that rituximab is as effective, but not superior to cyclophosphamide. What about plasma exchanges? Plasma exchanges is this very short treatment that we give to the patients very early in the course of the disease, especially when the disease is severe. In 1992, our group showed that when you compare steroids to steroid plus plasma exchanges, survival is the same. And later on, in another study on GPA, we demonstrated also that steroids and cyclophosphamide are not different in terms of survival on steroids, cyclophosphamide, and plasma exchange. And more recently, in 2020, the different vasculitis group all over the world joined their efforts and studied the indication of plasma exchanges versus pulse methylprednisolone and oral steroids, and they treated patients with cyclophosphamide or rituximab. It was a randomized control study with 2 randomizations, one for plasma exchange and the other for corticosteroid dose. And the results are shown here. And they are interesting, but they need to be commented. If you look at plasma exchange, you see that the 2 curves are exactly the same. And it showed, in fact, that there is not additional benefit to give plasma exchange early in the course of the disease in terms of survival. And if you look at the steroid, it is the same. You can treat with less steroid than we did in the past. But there is some residual indication for plasma exchanges. These residual indications are, in fact, the refractory patients, the very, very early patients, for instance, with an extensive neuropathy, and in some fresh involvement of the kidney. And it has been very well discussed in another, in the comment by Falk, the editorial which was published together with this paper in the New England Journal of Medicine. Plasma exchanges can be effective as a second-line treatment. They are also very effective in severe alveolar hemorrhage. And this treatment, even it hasn't been shown by a prospective study, is used by all the clinicians all over the world, and maybe in some very acute, extensive, and severe diseases. In fact, one of the major problems is how to prevent the relapses, and it is a choice of the maintenance treatment. In the past, we made a lot of progresses. Because if you remember what happened before at the end of the 20th century, we gave oral cyclophosphamide or pulse cyclophosphamide for a very long time. But the patients, in fact, can be treated differently. And in this study, coming from the UVAS, the comparison of 3 to 6 months of oral cyclophosphamide, then azathioprine, versus 12 months cyclophosphamide showed that there is no difference between groups. And now everybody treats with a short cyclophosphamide treatment when they use cyclophosphamide. In this study, we were concentrated on the maintenance treatment. All patients were treated initially with pulse cyclophosphamide and after randomized between azathioprine or to receive methotrexate. And you can see that the results are the same. Methotrexate is not superior to azathioprine, which is not superior to methotrexate. But what it is a study from my group, and when I look at these results, what I see is that after 3 years, half of the patients have relapsed, which is not a very good result. It is not acceptable. And the conventional immunosuppressant to maintain the remission is not a very good treatment. Here it is a comparison of azathioprine and mycophenolate mofetil. Mycophenolate mofetil is not the best drug. Azathioprine is superior to mycophenolate mofetil to prevent relapses. And personally, I use mycophenolate mofetil only when I cannot have another choice, but it is not my first choice to maintain the remission. It is summarized on these slides. And when you look at the vegan study, the IMPROVE study, which was a comparison of azathioprine and mycophenolate, or the main reason, and we will comment, conventional treatment is not the solution to maintain the remission. Here it is a RAVE study. The RAVE study was an induction treatment, and induction of remission was randomized 2 arms, steroids and cyclophosphamide in 1 arm, followed by azathioprine, and rituximab for infusion and nothing after, placebo. The publication was made after 6 months, and after 6 months, you have a good response. The primary endpoint, which was no activity of the disease and no corticosteroids, approximately 50 to 60% of response, and the clinical difference of 11% between the groups met the criterion for non-inferiority. If you look at the same study at 18 months, what you observe is very interesting. It's very interesting because the survival rate is exactly the same between groups. Remember, in one group after rituximab, patients did not receive any treatment, placebo, and in the other groups, they received azathioprine, which means that when you induce the remission with rituximab, you obtain at 18 months exactly the same response, therapeutic response, than to give oral cyclophosphamide than azathioprine. But at 18 months, 40% of the patients have relapsed. And for my group and other colleagues, it is not acceptable. And it is why now we really recommend to give a maintenance treatment to patients and not to stop after 4 rituximab for induction and to wait for the relapse. It is a publication on this main recent trial, a trial which compared azathioprine for maintenance. All the patients, including the study, are in remission, of course. They have GPA and NPA or MPA, but not other vasculitis and no eGPA. And we compared azathioprine to pulse rituximab every 6 months at low dose, 500 milligrams. And we evaluated the patients at 28 months. Look at the results. In the azathioprine group, 17 major relapses, 28%. In the rituximab group, 5% relapses. And the survival is excellent. It's comparable in both groups. There is some deaths in the azathioprine arm, but except one, they are not related to the vasculitis. And when we compare the long-term results of this study after 60 months, remember, we evaluate at 60 months. Some patients have relapsed, but the trial was stopped at 18 months. And after, of course, they were treated according to the good clinical practice. Some relapsed, some did not relapse. And you see the major difference between the azathioprine group and the rituximab group. The rituximab group, of course, there is less relapses, but we can say that there is no relapse. The patients treated with rituximab, when you stop rituximab, some of them do relapse. The superiority over azathioprine is clear. And the conclusion is rituximab is more effective than azathioprine to reduce relapse rate in ANCA-state vasculitis. What does it mean? It means that the choice for maintenance now should be in systemic disease, rituximab, and not azathioprine, non-methotrexate, and not mycophenolate mofetil. The prevention of relapses, the maintenance treatments, when you treat initially with cyclophosphamide, treatment implicates a maintenance treatment with rituximab. If you choose rituximab for induction, you can have a different choice for maintenance. You can wait, and maybe that you can select the population of relapses and to treat only this subpopulation of relapses. But the major question is how to identify these patients who will relapse. How we can adapt the treatment to biological markers. We tried that. And for that, we built another trial, and we tried to adapt the treatment to CD20 or to the presence of ANCA. We had a first response to the interest of immunological markers coming from the studies, the long-term follow-up of the RIF study. You can see that independently of the treatment, when you are anti-MPO, you relapse less than when you are anti-PR3. And in the MenRITSEN-2 trials, we made that all the clinicians do. They try to monitor ANCA, they try to monitor CD19, they are anxious when there is a high titer of ANCA, but what to do in fact? And for that, we made a trial. We compared the conventional treatment for us now, which is rituximab for maintenance, 5 infusions, to an on-demand injection of rituximab. We monitored the patients every 3 months, and when there was an increase, the titer of ANCA or positivity of CD19, we decided to induce a treatment, a new infusion of rituximab. And the results, of course, showed a clear difference. The number of infusions on demand was 3 on approximately 2 years, and in the fixed dose 5. And the difference between the number of relapses and major relapses is not different between groups. And the survival is excellent. And if we look more carefully at the interest of CD19 and ANCA titer, there is no significant difference between both groups. In fact, after these 2 trials, the RAVE trial and our MenRITSEN trials, it is possible to have different subgroups. There is a subgroup of patients who will relapse very frequently. that the patients who are positivity of PR3 antibody at day 0 and who are still positive after 1 year. On the contrary, those who had GPA or MPA without anti-PR3, they relapse very low. Maybe they are also without any ANCA. And in between, you have the group which was anti-PR3 positive initially, but they lost their antibody under treatment. And they have an intermediate risk of relapse. And maybe that the future trials will really concentrate on these groups of relapses, and we will select the population of patients who need a treatment. We made also a MENRITZEN-3 trial, which was to prolong the immunosuppressant with rituximab every 6 months for 18 months, additional to the other trials, because these patients were a part of the group which was included in the MENRITZEN-2 trial. And the results are clear. More you prolong the treatment with rituximab, less relapse you will observe. It is brilliant, but there is a problem. The problem is rituximab, because if you treat patients during all life because there are relapses, there is a high risk of side effects and mainly infections. And we have observed that with the COVID pandemic. And I will come back on this point later. The American and European group has also promoted a trial which is very similar to the MENRITZEN trial called Ritazarem, with some differences. The first difference is the inclusion. The patients are more severe than in MENRITZEN trial, and they already have relapsed. And they received a very high dose of rituximab, 1 gram every 4 months. And the results are shown here. There is a difference between the rituximab group and the azathioprine group, but it is not really a surprise. What to do? To adapt the treatments to markers of disease severity. We have some markers of relapse, and we have identified some of these markers, but there is also some markers of severity. And the best is certainly the 5-factor score. And we have 2 versions, but the new versions, the more recent one, is age over than 65, creatinine 140, cardiomyopathy, when there is a specifically attributed to the disease, gastrointestinal involvement. And we also observed that involvement of ENT, when present, confers to the patients a better prognosis than when they do not present ENT involvement. I would like to show you in the best groups, the groups without with FFS 0, that we have also to think differently to the treatment. It is an old study called the Schussman study. And this study was concentrated on PAN, NPA, and eGPA. No patient had severe criteria. And our question was, is it really useful to give azathioprine combined with steroids as induction treatment, or to give a placebo in place of azathioprine? And when you look at the 95 randomized patients, you see the remission without relapse, the same in both groups, the remission rate, the same in both groups, and the number of deaths, no difference. And what does it mean? It means that, in fact, when you have a very low active disease, a minor disease, steroids alone can be sufficient. It can be enough. And to give azathioprine or methotrexate with the intention to reduce the steroid treatment has not been really demonstrated. The curves on steroids in both groups were exactly the same. What about the reduction of corticosteroids? We don't know. We do not have the answer. You have seen the randomization in the Pexivas trial demonstrated that we can treat patients with half corticosteroids. But to treat patients with half dose corticosteroids is 1 point. But here it is not the same question. It is also, can we stop corticosteroids earlier? And nobody knows, in fact. There is this retrospective study with 14% relapses in the non-zero corticosteroid target dose and 43% relapses in the zero corticosteroid target dose. It gives some argues to say that it is better to keep patients on very low dose steroids, but on the other side, you know also that corticosteroids can be severe. Now there is some ongoing trial, withdrawal, VCRC, Pexivas, and the French Vascular Study Group has also one trial. I would like now to show you some points on the economic, because the new drugs are expensive, as I told you. And the UK people use very frequently what they call the QALY. QALY is a cost of 1 year for a patient with a new drug with a very good quality of life. And you can have, with the current treatment, QALY, which is what we know. With a new treatment, first of all, you can have a QALY loss, and of course, it's not good treatment, and you can have gain in QALY. And we have studied the medico-economical aspects with rituximab in the MAINRITZEN-1. The cost for 1 year treatment, combining everything, loss of work, hospital, drugs, and so on, nurses, it's approximately 57,000 euros. And it is considered by the European and American community to be a good quality. But when you compare both groups, and when you look at the cost effectiveness of new drug, the best item is the ICER, the incremental cost effectiveness ratio. And it demonstrates that to have the drug, which is considered today to be the best tolerated and to be as effective as cyclophosphamide, you have only to pay 200 euros more than to give cyclophosphamide and azathioprine after. Now I would like to move to the EGPA treatment. Mepolizumab is one of the new drugs. We have not the same advance in the knowledge on mepolizumab. Mepolizumab is a drug which is very effective on eosinophils and very effective on asthma. And it has been studied also in EGPA with the objective to reduce the corticosteroid dose and to prevent the occurrence of relapses. And in the paper by Wexler, published in the New England Journal of Medicine, you can see that EGPA treatment, it is clearly superior to give mepolizumab than placebo. It is, of course, a treatment given as add-on therapy on steroids and immunosuppressants. And when you compare the relapse in one group and the other, you see that patients treated with mepolizumab have less relapses than the other group. And for maintenance, I think that mepolizumab is a good choice. Now, can we treat initially all patients independently of the severity of the disease with mepolizumab instead of cyclophosphamide or steroids? It is too early to answer. Personally, I think that with the knowledge we have now, we have to induce the remission with the conventional treatments and maybe after to switch to mepolizumab. The big advantage of mepolizumab is that in half of the group of patients included in this trial, it has been possible to stop corticosteroids. And most patients were able to reduce the corticosteroid dose, which is essential for these asthmatic patients because they take steroids all life, and sometimes they die because of steroids and not because of the disease. And reducing corticosteroids with asthma or without asthma is certainly an objective for the future. Now, I would like to go in the same way and to try to understand if it is valuable to give a new drug, which is avacopan. Avacopan is a drug which is a C5a receptor inhibitor, and this drug has been clearly studied in ANCA-associated vasculitis. And this group of patients, here is the design of the trial. They receive 30 milligrams twice a day or placebo, prednisone also, then a tapering scheme, of course, of prednisone. They receive rituximab initially, or cyclophosphamide IV, or cyclophosphamide oral, and there are no maintenance treatment. And which for me is a problem, but I will show you the results. When you look at the results, there is a slight difference between the prednisone and avacopan group. And it means that avacopan is slightly superior, but it was slightly superior only at 12 months and not at 6 months. And we need, I think, more studies to know if we should replace, for induction of treatment, steroids by avacopan. I don't know. Avacopan is still under studies because this drug has other advantages. And one of the advantages is probably to improve renal function. And if it is demonstrated on a very large number of patients, it will be really a great advantage for the drug. Avacopan was not superior to the progressive tapering of prednisone at 26 weeks, but superior at 52 weeks. Adverse events, we do not have enough information. And the major flaw is, of course, the absence of maintenance treatment with rituximab, because with rituximab, we know that the number of relapse drops very frequently. Genetic markers now. It is the future. GWAS has been done for GPA and MPA, with a lot of patients coming from UK and the European replication cohort. And you can see that when you divide the patients based on clinical symptoms or on ANCA presence, there is not exactly the same population of patients. And what has been identified is that the genes or the HLA associated with antiproteinase 3, GPA, MPA, but also with GPA, HLA-DP for anti-PR3, alpha-1 antitrypsin gene for GPA, and also another gene, which is PRTN3. It is in the group of GPA patients. For anti-amylo peroxidase, the different HLA. And in GPA, a subgroup, HLA-DQ, has also been identified. And when patients are not anti-MPO subgroup, there is no HLA, but other variants, genetic variants. And it is very interesting because, of course, it is not used like we use B27 to help you to make the diagnosis of spondyloarthropathies. But who knows what will happen later? Maybe we will have to divide the patients in subpopulations according to HLA groups, for instance, some genes, to have a better choice of treatments. We don't know. The impact of genetic markers. maybe the determination of subgroup of relapses, markers of prognosis, we don't know, but we have to look at that. And I would like to finish this talk with this slide. These slides are on the COVID-19. COVID-19 kills patients, we know that, but it kills also our vasculitis patients, and not only the ANCA-associated vasculitis patients, but here it is deaths also in GCA patients. But in ANCA-associated patients, they have been treated with rituximab. They have a very profound immunodepression, and you can see the results: 15% deaths due to the COVID, and 23 patients ventilated or received oxygen therapy. It is a lot. And the characteristics of poor outcome of patients are the age, the male sex, comorbidities, prednisone, and moderate or high disease activity. And before the conclusion, some prophylactic measures to avoid these side effects. And first of all, you have to vaccinate your patient. You can do that, and you have to do that. It has been done by our group and in a study, and also by the group of Peter Villiger in Switzerland in rheumatoid arthritis. And we observed that most patients have very well tolerated vaccination. It was again H1N1 at that time, but there is some vasculitis flares which were temporarily related to vaccination. Do not forget the prophylaxis for pneumocystosis, against pneumocystosis. And 2% of patients with taking rituximab have these side effects. And you can prevent the side effect by cotrimoxazole that you should stop only when immune reconstitution has occurred, not after the end of treatment. Do not stop cotrimoxazole and immunosuppressant and corticoids simultaneously. Stop only when immune reconstitution is obtained. Prophylaxis against TB. Fungal, there is no systematic prophylaxis. And for viral infections, there is no systematic prophylaxis except for those who have herpetic manifestations, and you can provide valacyclovir systematically. And against COVID, vasculitis are not diseases with favor the occurrence of COVID-19, but the concern is a prolonged B-cell immunosuppression induced by rituximab. Most patients do not develop anti-spike antibodies and are therefore at risk for COVID-19. And now, with Omicron, we have one drug which is helpful, which is Evusheld, and we propose this quite systematically to our patients who have been treated with rituximab and who have a profound immunosuppression. The conclusion: treatment of vasculitis has really improved dramatically over the last decades. Survival improvement had already been obtained with optimal use of conventional treatments. And if you have conventional treatment, you can treat successfully your patients. Fewer relapses and better long-term tolerance seems to be related to biotherapies and especially to rituximab. The future progress will probably come from treatment optimization, duration, adaptation to disease severity. And it is based on some markers of relapses, maybe some genetic factors. And because we have now a pandemic, we should also think to the limitation of the treatment and to the adaptation to the treatment, and to give the treatment to subpopulation of patients who really deserve it. We should not overtreat the patients. I thank you very much for your attention.